So I think I welcome each one of you for Diabetes Dilemma. I will repeat this announcement. This is not a big conference. This is kind of a weekend academic sessions. So more of a discussions, more of a informal. You can walk in and out, no issues. You can have your tea, coffee inside. You can stop the speaker. Though informal, we will start on time. So I think that I will have to make sure. Otherwise, it's not correct for the future speakers साठी. So and then it will be delayed and we won't have enough time for gappa after the dinner. So let's respect our own time for around dinner. So though informal, we will start. Is Dr. Pawar or Dr. Sanjay Thorat here? Okay, I will introduce them once his first part of talk is over. So let me invite Dr. Sharvil Gadhave, the hero of Kolhapur. I know he looks same for so many years. So I always think he's very junior to me, but it remains the same sentence. Endocrinologist, very academically oriented. We all senior people are very happy with him. He's always there for the help. Whatever we need, and I remember our session in RSSDI Pune, and because I always twist the scientific sessions and I need speakers who actually agree to me. So Sharvil, to you, and we will be discussing something about insulin secretion initially, and then something about basal insulins, the day-to-day clinically oriented topics. Again, I repeat, if Dr. Sanjay Thorat and Dr. Yuvraj Pawar is there, we will introduce them later. Over to you, Sharvil.
Thank you, madam, for that opportunity. Good evening, everyone. So, we start off with today's first lecture. So, first few slides, I will be touching upon basics of insulin secretion. So, we just look at the basic physiology of how insulin is secreted in our body. So, this is the beta cell. So, this cartoon shows the beta cell. So, we know that there is this GLUT2 channel. So, that allows the glucose to enter the beta cell. After this glucose enters the beta cell, there is this glucokinase, also called hexokinase 4, which converts it to glucose 6-phosphate. And ultimately, there is increase in ATP inside the beta cell. Now, what is important to understand is that this particular glucokinase called hexokinase 4 does not follow feedback inhibition. What that means is that suppose today we have a very heavy dinner with lot of sweets and our glucose goes very high. So let's say the blood glucose has gone very high, so that all that will translate into high glucose 6-phosphate and very high ATP inside the beta cell. So it is directly proportional and there is no feedback inhibition. Now in physiology, that is in a very healthy individual, there is a very fine tuning of this whole physiology to maintain normoglycemia. It's a perfect biochemistry set in by nature. What happens is that you eat food, your blood glucose goes high. So this is the blood glucose which is high. That leads to higher glucose inside the beta cell. That leads to higher ATP. Now when there is high ATP inside the beta cell, that leads to inhibition of the potassium gated channel. So high ATP leads to inhibition of this potassium gated channel. What that means is that there is no efflux of potassium outside the beta cell. So there is high level of potassium inside the beta cell. That leads to depolarization. This depolarization leads to opening of the calcium channels. So that leads to entry of calcium into the beta cell. And that calcium which enters here, that leads to exocytosis of the preformed granules that are present, which are having insulin. Right? So this is how this is working. Now let's say today evening you fast, and if you don't take dinner today, and you go to sleep. So basically at night, your insulin secretion should fall down. So how that happens is that if there is low glucose here, there is less glucose entry here, so there is less of ATP which is getting produced. So the potassium channels stay open. So the potassium efflux keeps on happening. So there is no depolarization. In fact, there is hyperpolarization. So opposite of depolarization. So the calcium gated channels stay closed. So the insulin is not secreted. Right? So now we see here, there is this nucleus and there is something here called the endoplasmic reticulum, the rough endoplasmic reticulum and the Golgi apparatus, right? So we know that in insulin secretion, there is phase 1 insulin secretion and phase 2 insulin secretion. Now what is phase 1 insulin secretion? Let's say today we have a sweet dish, we eat something which is very sweet. So immediately there is spike in glucose and the preformed granules are released. But the second phase insulin secretion continues. So there is the entire process of mRNA, then translocation, then formation of pre-proinsulin, then proinsulin, then insulin. So we'll come to that in the next slide. So this here shows how intricately blood glucose determines whether the beta cell is producing insulin or not producing. Now we know that in type 2 diabetes, all this is going on fine, and at some point, the beta cell defect comes forward. Insulin resistance may be there for several years, but that may not translate into diabetes. But when there is a factor of beta cell dysfunction, that is the time when patient presents as diabetes. Now, this is about insulin release. What about insulin synthesis? Now we know that this is pre-proinsulin, then there is formation of proinsulin, then the formation of mature insulin. Now what is the first step? The first step is the ribosome here. So from the mRNA, it produces pre-proinsulin. Then the ribosomes push this pre-proinsulin into the rough endoplasmic reticulum. So we know that the rough endoplasmic reticulum has an inside and outside. So it will push it inside here. So that completes two steps, translation and translocation. Now once it is here, it has to undergo different changes. First thing is it should have these disulfide bonds. That is very typical of insulin. So those bonds are formed, and then all this enters the Golgi apparatus. And here we see there is this very important step. These proteases cleave C-peptide from proinsulin. So the C-peptide gets cleaved. So we know that there is equimolar amount of C-peptide to endogenous insulin. So that is why we use C-peptide as a marker of endogenous insulin secretion. And then there is one more step which is mediated by this carboxypeptidase E. And that leads to some truncation of some terminal amino acids. And that finally leads to insulin. So all this is happening after we eat a meal. So this is the entire thing. So the first phase insulin is immediate release of these preformed granules. And the second phase involves all this. Now, what do we do? Let's say some patient has type 2 diabetes. One very commonly used drug is sulfonylurea. Now, where does this sulfonylurea act? It acts on this potassium channel. So, it is acting on potassium channel. So, this very potassium channel which is regulating everything. So, you give a sulfonylurea. Let's say you prescribe a glimepiride to your patient. It will act on this sulfonylurea channel and it will lead to insulin secretion. So that is how it is working. And there are number of other genetic etiologies now possible. So if you look at the different types of diabetes, be it MODY, maturity onset diabetes of young, be it the maternally transmitted diabetes, that is mitochondrial diabetes, everything now can be pinpointed to a genetic defect. Unfortunately, still we are far away from the classical garden variety type 2 diabetes. It's a polygenic trait. unlike the monogenic diabetes, the typical garden variety type 2 diabetes is more heterogeneous disease. But we need to know that we can, in the large number of diabetes patients, we can be specific and we can go and get a etiology if it is pertaining to some monogenic defect. So this is how it works. Now it's not just as simple as glucose as a stimulus. Now let's say somebody takes a full fat meal or a full protein meal. Will that lead to insulin release? Yes. There are a lot of alternative mechanisms also. So if you see here lactate, pyruvate, that also has a receptor. And the GLP-1, the present blockbuster drug, semaglutide. So GLP also have receptors on the beta cell. What they do is they lead to increase in cyclic AMP, and that augments the calcium mediated exocytosis of the preformed granules. So that is one thing here that is happening. And we know that there are various players here. There is this zinc transporter 8. Autoantibodies against zinc transporter 8 is one of the etiologies of type 1 diabetes and so on. So multiple mechanisms. Now coming to GLP-1, if the incretin based therapies, one of the most commonly used therapies is DPP4 inhibitors. Very, very cost effective, very, very easily available. So whenever you give DPP4 inhibitor, there is some increase in GLP-1. Now in physiology, there is good GLP response in body, but in diabetes, the incretin based pathway is affected. So when you augment that, when you give either a DPP4 inhibitor or you give GLP-1 in a very supraphysiologic dose, that leads to activation of that pathway, which is otherwise suppressed in type 2 diabetes. And phase 1 and phase 2, insulin secretion. So very important to understand that 75 gram OGTT may be the first test you would like to do whenever you are suspecting type 2 diabetes. Because 75 gram OGTT will lead to unmasking, which probably you may get a normal fasting glucose. HbA1c may be done, but we all know that it has multiple factors which can affect the result output of HbA1c, be it hemoglobinopathies, various factors. But 75 gram OGTT is a very simple, cost-effective test which can be easily done. And that leads to, we can realize that the patient has lost the, this particular surge in insulin that should happen to have normoglycemia. So that was just in brief about insulin secretion. So any questions, any thoughts on it? Yes.
Remind ourselves about back to basics, and I think we all need that, and you feel good to listen to the basic physiology always. So thank you so much.